Thank you, Dr. Mohammed Abul, and thank you, Dr. Noura. Dear audience, our last session, inshallah, will be presented by Dr. Mohammed Al-Ghanim. The lecture is about antimicrobial stewardship at ICU setting, challenges and solutions. Dr. Mohammed Al-Ghanim is one of our pioneers in antimicrobial stewardship. He has great interest. He did his postgraduate medical training in pediatrics, infectious disease, and medical microbiology in McGill University in Montreal, Canada. And after graduation and completion of his medical training, he worked as infectious disease physician in the MBK Children's Hospital in Sabah area, and the Kuwait Cancer Control Center, KCCC. During the pandemic of SARS-CoV-2, which was started last year, he was a member of several national-wide committees, notably the Pediatrics COVID-19 Task Force and the National COVID-19 Vaccine Committee. Dr. Mohammed Al-Ghanim has many interests in infectious diseases, most notably the infections in immunocompromised hosts. And he has special interest in improving the quality of clinical and laboratory care provided to patients and institutions. Lastly, he has published several and many papers throughout the years, most notably about respiratory viruses and diagnostic accuracy and quality of improvement. So I would like to welcome Dr. Mohammed Al-Ghanim, and Dr. Mohammed, the mic is yours.
Thank you, Dr. Hussein, for this introduction. And it will be difficult to present after all the previous presenters. We had great lectures for the past almost 3 hours. I'll present today about antimicrobial stewardship, basically starting with the why do we need stewardship and what stewardship is, and then we'll gear toward the effects or the outcomes of stewardship programs and how to establish an antimicrobial stewardship. And I hope with the knowledge acquired in this brief lecture is to address needs that require and promote establishing antimicrobial stewardship programs in all hospitals in Kuwait. And I'll give a brief 2 examples of antimicrobial stewardship programs that were conducted here in Kuwait. So to begin with, the main problem or the main need to drive antimicrobial stewardship is the wide inappropriate use of antimicrobials. I'm sure all our audience are aware of that, and they can see that on their daily clinical practices. And the most common reason I come across on prescribing antibiotics is just in case. I mean, yes, the patient is admitted in the hospital, maybe he gets an infection, let's start antibiotics just in case. Or a patient admitted to the ICU, and yes, we'll start antibiotics just because he's in the ICU and just in case he has an infection. And this happens on a daily basis and in every ward, in every emergency room consistently. And that results in prescribing antibiotics for the wrong indication, prescribing the wrong spectrum of antibiotics, the wrong dose, and the wrong duration. For example, sometimes say, yeah, just in case, give him 14 days instead of 10, or just in case, give him 2 grams instead of 1 of ceftriaxone, for example. And it has been established in many randomized controlled trials that shorter is better with antibiotics, and that short courses of antibiotics are as effective as longer course of antibiotics. But I'm sure that most of the audience here and what they see in their clinical practice or in their hospitals, for example, you almost never hear someone prescribing a 5-day course of antibiotics for a community-acquired pneumonia. I will be surprised even if someone prescribed just 7 days here in Kuwait. The same thing with pyelonephritis in adults. You rarely see someone prescribe antibiotics for 7 days. Most people prescribe it for 10 or 14 days. And the examples are vast and wide. And this creates a big problems. For example, in the GLASS registry, the Global Antimicrobial Resistance Surveillance System, part of the WHO, where it surveys different or the degree of resistance in different countries internationally. Unfortunately, Kuwait is not part of the GLASS registry. For example, Klebsiella pneumoniae from blood isolates demonstrates that the range of carbapenem resistance internationally ranges up to 65% in certain countries. And for third generation cephalosporin, there are countries with 100% resistance against Klebsiella pneumoniae from blood isolates. And this is very alarming. The trend towards a more resistant organism and difficult to treat organism is rapidly increasing. On the other side, the number of antibiotics in the pipeline are extremely limited, and most of them are within a same established antibiotic groups. For example, in this graph, you can see that between 2014 to 2020, over the last 6 years, there have been only 14 newly licensed antibiotics. And among those 14, only 3 were in a new class. And among the 3, only 2 are expected to treat multi-drug resistant gram-negative organisms. And that includes meropenem vaporbactam and ceftazidime avibactam. And with ceftazidime avibactam, resistance already there, and we can see it even here in Kuwait in our daily practice. And the other antibiotics are basically on a newer antibiotics on a known class of antibiotics with probably the same resistant profile of previous classes, except for there are few exceptions, but this is the general case. And you can see even in antibiotics in phase 1, phase 2, phase 3, those that are in novel antibiotics are also in a small proportion. Specifically in the ICU, just focusing on the topic of the lecture, studies varied, but up to 70% of all ICU patients receive antibiotics. And more than half of the antibiotics prescribed may be inappropriate, either in indication, choice, or duration. And the reasons behind poor antibiotic choices in the ICU: first, diagnostic uncertainty. Patient will come with hemodynamic instability. Sometimes it's difficult to differentiate whether it's a non-infection related systemic inflammatory response syndrome or whether it's sepsis. And on the other hand, there's the fear of inadequate coverage, where you get someone with sepsis. Most of us, and this is very reasonable, worry that there might be a resistant organism that is not covered with the empiric antibiotic choice. And this leads to increase in multiple antibiotics used, the use of broader spectrum antibiotics, and creates also resistance to de-escalate or to stop antibiotics when the cultures come back. And as already mentioned, that the challenges in antibiotic use in the ICU include that there is overlap between syndromes such as sepsis and SIRS, and there is the hesitancy to escalate or discontinue antibiotics because the patient is sick, and we hear that almost on a daily basis. And there's also, more importantly, and I would like to emphasize on that, especially with all my medical microbiologist colleagues in this talk, that there's a lot of imprecision in microbial sample collection. And which leads to treatment of colonization rather than an infection. And a prime example of that is treating an ETT culture or a tracheostomy culture in a patient with a normal chest X-ray. And there's also poor definition of antibiotic duration, especially in unstable patients with negative cultures, because ICU attendings tend to get worried of stopping antibiotics in patients with no proof of systemic infection. And in those, we go back to the same notion earlier mentioned that, yeah, let's give him longer course just in case. And as already mentioned earlier by Dr. Sarah, that there's suboptimal pharmacokinetics and pharmacodynamics target attainment in ICU patients. And part of that, unfortunately, in Kuwait, we lack trained clinical pharmacists in infectious diseases, and that creates this gap of suboptimal PK/PD. Also, in the ICU, the other challenges is that there's lack of local management guidelines in general, and there's also lack of or inadherence of care bundles. For example, ventilator-associated pneumonia bundle or central vascular catheter care bundle, or even catheter-associated UTIs prevention bundles. So now, after understanding all the challenges of antimicrobial use and antimicrobial stewardship in the ICU, we move forward to understand what stewardship is. Stewardship in general, not specifically talking about antimicrobials, is a set of actions which promote the responsible use of healthcare service. And this could be on an individual level, either by a single healthcare worker or a patient, or at an institutional level, national level, or a global level. For example, a good example of global level initiative is the One World initiative, where there's a goal of reducing antimicrobial uses not only in the human, but also in farming and animal industries. And there's many targets of stewardship initiatives within a healthcare institute. For example, it could be appropriate use of antimicrobial agents, and this is the main goal of an antimicrobial stewardship program, but also could be responsible ordering of laboratory tests or imaging, or the right use of medical equipment or procedure, and the use of standardized procedure or institutional guidelines. These are all forms of stewardship that are not targeted against antimicrobial uses. And all those initiatives will improve the quality of care provided to patients, and also will reduce the healthcare cost as a bystander. Moving towards antimicrobial stewardship, it's simply, or the shortest definition of it and the easiest to understand, is basically steps on two principles: the responsible use and the appropriate use of antimicrobials. And this use could be further subdivided into the antibiotic indication, choice, dose, route, and duration. The IDSA, the Infectious Diseases Society of America, defines the antimicrobial stewardship as a coordinated intervention designed to improve and measure the appropriate use of antimicrobials by promoting the selection of optimal antimicrobial drug regimen, dose, duration of therapy, and the route of administration. Why do we do, or why antimicrobial stewardship is important? Basically, it's a very long list, but the short and most important points we'll go over in the next few slides. First, it's to improve patient outcomes. Antimicrobial stewardship program increases the chance of correct empiric therapy. And with that, it decreases mortality, and there is many observational studies that showed that different antimicrobial stewardship intervention led to decreased mortality and decreased disease-related complication. Also, with stewardship, it leads to shorter length of hospitalization because of the appropriate duration and early switch to oral antimicrobials. And there are also many observational studies showed that antimicrobial stewardship program leads to less disease recurrence and or readmission. Also, stewardship programs lower the rate of adverse events. And basically, I'm mentioning here 4 different studies that look into that specifically. So there is a wide spread notion that antibiotics can't hurt. And this is completely wrong. Antibiotics can hurt, and personally, I see severe antibiotic-related complications on an almost daily basis. Yes, they're not common, and antibiotics generally are safe, but no, they can hurt. They can hurt on a short-term duration with drug-related adverse event, and they can also hurt on a longer-term duration by widespread of resistance. So in a paper by Bagus and colleagues, showed that high-risk antibiotic exposure, and the high risk here are the common antimicrobials that we use. So third-generation cephalosporin, fluoroquinolone, trimethoprim, sulfamethoxazole, showed that exposure to antibiotics in the last 90 days is associated with 65% increase of risk of subsequent sepsis. So basically, because believe that antibiotics exposure disrupts the normal flora, and this leads to first to a more pathogenic bacterial colonization and a more resistant organism. Also, and this is a common sense, that certain antibiotics will increase the risk of nephrotoxicity, and combination antimicrobials, for example, such as piperacillin and tazobactam, potentiate the risk of nephrotoxicity with other nephrotoxic antibiotics, such as vancomycin. Also, other observational studies showed that less antibiotics is associated with less adverse effects. For example, in a study comparing, this is a clinical trial comparing a shorter duration for community-acquired pneumonia. There was a trend towards fewer mortality and adverse events in the shorter course. Also, in another trial, where comparing a shorter course for pyelonephritis, there was a trend towards lower adverse events, and there was also less candida infection. Also, the decrease in use in antimicrobials is associated with lower antimicrobial resistance. This is in a large observational trial in Hong Kong, where it compared 3 different centers that used, in Taiwan, 3 different centers using 3 different antimicrobial initiative, where in hospital A used the pre-authorization in all medical wards, plus feedback. B used the pre-authorization only in ICUs, plus prospective audits and feedback in all wards. And then C used feedback only. And as you can see in the graph, that hospital A and B generally had lower antimicrobial uses because it had more stricter antimicrobial stewardship program compared to hospital C. And with that, you can see that, for example, in E. coli, Klebsiella pneumonia, it's across the board. Pseudomonas aeruginosa and Acinetobacter baumannii, that percent susceptible organism is much lower in hospital C, where the antimicrobial use was higher. And this is just a direct relationship between higher antibiotic use leads to higher resistance. And another observational study that looked into a center where they had cascaded antimicrobial initiatives starting between 2009 to 2013, you can see that there was a trend or a decline in antimicrobial resistance in almost all classes, except for the non-carbapenem antipseudomonal beta-lactams. And because there was a switch between a certain class of antibiotics to another class of antibiotics, but that's okay, because if you can see that the amount of decline in all classes is not even comparable to the increase in a single class. And that's the same thing showing in different organisms, and what antibiotic classes had a significant drop in susceptibility. The last point that where antimicrobial stewardship has a tremendous success is that antimicrobial stewardship and decreased antibiotic use is associated with lower Clostridioides difficile infections. And the largest prospective national level data from Scotland showed that the reduction in the 4C antibiotics, basically fluoroquinolones, clindamycin, cloamoxiclav, and cephalosporin, as you can see here, between January 2007 to July 2009, and as measured in the black solid line on top, and against to CDI's infections in Scotland as divided by the colored graph, and it's divided by the ribotype of C. diff. As you can see that after implementing the 4C antibiotic stewardship, there was a significant drop in those antibiotic prescription, and that was associated with almost line to line, like the line was parallel, a drop in CDI rate. So now we understood what stewardship is, what are the challenges in the ICU, and why stewardship is important, and how to improve patients' quality of care. Next, we'll go through how to establish an antimicrobial stewardship program. So there are three main points in establishing antimicrobial stewardship program. The first is the structure organization, or how to establish an antimicrobial stewardship team. Second is the intervention that need to be implemented, and the intervention could be on two main areas. First is the clinical part, where intervention are implemented in wards, emergency room, or outpatient clinics. On the other side is what could be implemented in the laboratory, and specifically speaking here on the microbiology lab. Then every intervention and every quality improvement intervention need to be measured, or the change need to be measured. And here we talk about the quality metrics. The main two quality metrics are defined daily dose, DDD, not DDT, sorry, and DOT, or days of therapy. And there are many other metrics that could be followed depending on the availability in each center. So establishing an antimicrobial stewardship program, it's not as simple as it sounds. There are many key players that need to be integrated into the stewardship program. So, but of all those main players, there are two who are fundamental. The first key player should be a champion among the clinical team, and this is extremely important. What I mean by a champion, so for example, if you are establishing a stewardship program in an ICU, you need to have one of the ICU attendants or consultants to be on board with the establishment of stewardship program. Otherwise, the program will fail. There will be no uptake of the recommendations, and establishing the program will not be as simple or easy. And I'll show you an example at the end of the presentation of how having a champion is very important. The second stake player in this program is an expert. And an expert could be an infectious disease specialist, could be a medical microbiologist, or an infectious diseases clinical pharmacist. You need someone who is comfortable in giving antimicrobial decisions, and is up to date with the most recent recommendations and guidelines, and have expertise in choosing antibiotics, or feels comfortable in de-escalating antibiotics, or switching to oral, or and so on. And apart from these two, you need a person who could be one of those two, but usually it's a third person who have the time to collect data and organize it. You need someone who can keep record of all changes and all recommendation and track changes on a larger level. Other key player that could participate in the stewardship program is infection control, and as mentioned earlier, that nosocomial infections and hospital-acquired infections are an important part in ICUs. So having someone from infection control could be a very valuable asset to the stewardship program, where it could emphasize the need for special care bundles and a specific infection control intervention. You might also need an information technologist, where could create a program or a software where you can track changes electronically, and can help with analyzing the data you have. Nurses are also an important part of stewardship program, because nurses, especially in the ICU, where it's usually 1-to-1 or 1-to-2 ratio with patients, nurses will have a closer and look and micromanaging each patient, where any changes in antibiotics or culture results, or they will know it first, and they can flag any potential changes with the treating team. Hospital administration input into helping establishing the stewardship program is important, where they could ease up difficult obstacles in establishing the stewardship program. And having an infectious disease specialist, microbiologist, pharmacist, and treating physician is a no-brainer. That those are key players. And the stewardship program need to set up a short and long-term strategies. And that means, what is the short-term strategies? For example, lowering CDI rate, or lowering consumption of a specific antibiotics. Doesn't need to be a global, or like all antimicrobials. Could be targeting a specific classes of antibiotics. And there should be a longer term strategies, and longer term usually, and lowering, for example, antimicrobial resistant organism, or in lowering overall antibiotic consumption in the ICU, or it could be lowering antibiotic related adverse events. Then we'll move ahead. So after the antimicrobial stewardship program is established, the program need to set up a list of interventions that can be implemented, and the list of or the intervention doesn't need to be all at once. It could be a single intervention at a time, and this is most of the stewardship program. That's what is done, where a single intervention is implemented until it gains acceptance among treating teams, and then a second intervention is added, and so on. And the intervention could be divided into clinical activity interventions, microbiologic lab interventions, and institutional level activities. For the clinical activities, the most common antimicrobial stewardship intervention includes restriction and pre-authorization, audit and feedback. And these are the two most common and the two most widely used. But other intervention could include establishing an antibiotic order sheet, where indication and duration are clearly stated from the beginning, and that will limit forgotten antibiotics. And surprisingly, it happens in all hospitals around the world, where antibiotic is prescribed and gets forgotten until 10 days after or 2 weeks after, where someone reviews the medication sheet or do medication reconciliation and finds out that there is an antibiotic that's been there without an indication. Certain institution implements a 48-hour automatic stop for empiric therapy, where an empiric therapy, when it starts, you get only 48 hours approval, and after 48 hours, you need to re-prescribe the antibiotic, and that will help in choosing a more appropriate antibiotics when cultures are available. So there's also programs that implements infection source control. For example, if someone have a collection, that collection needs to be drained as soon as possible, where a protocol is set in place that includes interventional radiologists, surgeons, and treating teams, where that protocol will facilitate a quick and rapid source control. There's the early IV to PO switch, artificial intelligence guided clinical decisions, where a software will guide the clinician to a certain in a certain clinical syndrome. So, for example, in a UTI, a software where you put the urine analysis data with the patient demographic data and symptoms can give you the risk of UTI in that patient, and based off that will give you a decision whether this patient needs to be treated or not. A program for pharmacokinetics monitoring, such as vancomycin level, aminoglycoside levels, and allergy delabeling. We all see patients with who claim to have allergy to amoxicillin, penicillin, or others, where in fact, if someone just sits and take a proper history, will realize that this patient doesn't have allergy, and they should be delabeled to prevent using alternative choices. That's all in the clinical activity. If we move to the microbiology lab, there's many things that could be done in the microbiology lab, that small changes in reporting can and processing can result in a tremendous changes in the clinical part without really affecting daily work. For example, releasing antibiograms should be a standard in every microbiology lab in this era, where it could help guide empiric therapies. Also using cascaded susceptibility reporting, and I'll give an example of that. Improving the lab processing to provide results with a shorter turnaround time. For example, resulting or giving the respiratory virus panel within 24 hours can result to shorter antibiotic therapy if that was enforced, for example, by a stewardship program. Similarly, providing microbiology lab providing guidance on specimen collection, on how to collect a specimen, or have a strict sample rejection criteria where inappropriate samples should not be processed. Also, to have an alert system for special pathogens, and most labs already have this established, but this could be also widened. And there's the overall institutional activities where involves the entire hospital, such as simple intervention, but also have a major impact, such as education and appropriate selection of antimicrobials, have a clear clinical policies and guidelines on the use of empiric therapy and surgical prophylaxis. For example, surgical prophylaxis should be used use the narrow spectrum antibiotic to target most commonly Staph aureus, and the patient should receive it as a single dose 30 minutes before the incision. What happens in practice that we see that broad spectrum antibiotics are being used and for unnecessary long duration. You can see some patients are on 3-day course of prophylaxis, 5-day course of prophylaxis, and I've even seen patients on 10 or 14 days course of prophylaxis where they continue antibiotic prophylaxis at home. And of course, to have enhanced infection prevention and control is a very important aspect in reducing an unnecessary antibiotic or preventable antibiotic prescriptions. If we go in explaining in each or the few major stewardship intervention. So the first two that I'm going to explain is restriction and pre-authorization, and prospective audit and feedback. And these are the two most commonly used by stewardship programs, as I already mentioned. So basically, if we imagine the blue line here is the antibiotic course, restriction and pre-authorization targets the antibiotic course before it begins. So there's certain high-risk antibiotics that what I believe should be restricted, for example, including meropenem or piperacillin tazobactam, where these antibiotics should be restricted and will only be released by the pharmacy if the treating team got a pre-authorization. Where prospective audit and feedback basically reviews the indication, duration, choice, and route of antibiotic administration in a pre-specified date through the antibiotic course. Each intervention has its own benefits and disadvantages. The benefits of restriction and pre-authorization that it's extremely effective and results in a rapid and significant reduction of inappropriate antibiotic use. And is also associated with rapid decrease in antimicrobial.
But you have 5 minutes remaining.
Okay. Results in rapid decrease in antimicrobial resistance and more effective in preventing CDIs. But the effect of restriction and pre-authorization is limited to the expertise of who's answering the call, basically. Whereas prospective audit and feedback has a benefit of providing routine education. And because of the shortness of time, I'll just go through the next slides quickly. There's also the educational activities, management guideline, prescriber-led intervention. They're all effective, but are not as effective as restriction and feedback interventions. And each one have advantages and disadvantages as well. Same thing, early PO switch. For example, it's very important because it leads to early discharge, hospital discharge, lower cost of care, and less hospital-acquired infection. Going into the microbiology laboratory quickly, I'm sure all microbiologists are aware of the CLSI guideline of M39 A4, and A5 is coming, should be coming in the next few months. But basically, having a stratified antibiogram and enhanced biogram is very important in stewardship activity, where you can see the resistant rate or the susceptibility rate of different organism or high-risk organism based on type of resistance, based on combination therapy. For example, in the last example here, all gram-negative bacilli from blood and respiratory sources. This could be targeted to ICU patients where antimicrobial combination or a monotherapy, empiric therapy, or a combination therapy could be justified in each case. And cascaded susceptibility reporting, basically, if I show you this susceptibility report for a lady with a UTI who was prescribed ciprofloxacin, you won't expect any change by the prescribing physician. But if the same patient with ciprofloxacin for a UTI and the treating physician gets this susceptibility report, because ciprofloxacin is not there, it will create some anxiety with the treating physician, and that would lead a change towards a narrower spectrum antibiotics, because the microbiology lab only limited that to those antibiotics. In case of resistance, then the microbiology lab could release the other antimicrobial susceptibilities. And just going quickly, that having an earlier blood culture reports or a preliminary blood culture report will also help in giving targeted antimicrobial, and having a shorter turnaround time for several tests will also aid in that. For example, in this study where, for example, enterovirus CSF PCR turnaround time was decreased from 4 to 6 days to less than 24 hours, resulted in shorter hospital admission by 2 days and shorter antibiotic intravenous antibiotic prescription by almost 2 days. Going through the quality metrics, the two that I already mentioned is defined daily dose and days of therapy. Days of therapy is the one most commonly used, and this is the one that is recommended. Is basically counting a day of antibiotic as a 1 day of therapy. If a patient is receiving 2 antibiotics, it's at 2 days of therapy, and it's more standardized and could be used to compare different institutions, whereas defined daily dose has a very long list of disadvantages. I only summarize them here, but it doesn't count into the actual dose and doesn't include pediatric patients, and many population cannot be part of that. And there's other types of metrics that could be used, but they're less representative of the antimicrobial use. So in summary, successful antimicrobial stewardship program will require a good team where you have a champion that promotes the antimicrobial stewardship. You need to build rapport with the treating team and take a small step at a time. Interventions, choose what fits best first and then modify as needed, and you should have metrics that follow the intervention and change. I'll give you 2 examples from Kuwait. They're both short, so I don't go over time. The first example, in a small specialized center where there was no stewardship champion, there was no effect, and you can see here with the days of therapy, there are almost no change of antimicrobial prescription over a 6-month period, and in all 3 wards, despite having almost a daily prospective audit and feedback, and all clinical guidelines related to that specialized center has been updated towards a more appropriate antibiotic use. And the reason for failure, what I believe, that because the treating team was not compliant and were not believing the prospective audit and feedback suggestions, and there was a unnecessarily prolonged use of antimicrobial therapy. Where the second example is the complete opposite. It was done in a pediatric intensive care unit where the ASP team comprised of a PICU team, 2 ID specialists, 3 microbiologists, and a clinical pharmacist. So it was a big team that met on a weekly basis to discuss only cases on intravenous antibiotics. And the ICU during that time updated their drug formulary to go along with the most updated guidelines on antibiotic doses and choices. And here in blue is the days of therapy per 1,000 patient days pre-antibiotic intervention, where the mean was in the 90 days of therapy per 1,000 patient days. And you can see that there was a decline, but this is an expected decline during the summer months. As you all are aware, and during winter, there are more respiratory viruses that leads to more antibiotic use. So that decline was expected. But after implementing the stewardship program, you can see that there's a tremendous difference in antibiotic prescription. The days of therapy came down from 90 to below 50 days of therapy per 1,000 patient days. And even if you compare month to month, you can see that there's a significant drop in antibiotic consumption. And here you can see the mean of pre and mean of post. And the decrease of antibiotic use, and here I summarized, the list was very long, but I just summarized what's the most antibiotics that experience a change. All antibiotic classes the use has declined significantly in ranges between 11 to 85% decline, except for ceftriaxone. And even with that, yes, the figure here is crazy, like there was 2,000% increase. But if you look at the days of therapy, it went up from 3 to 83. And that was partly because cefotaxime went down from 434 to 192. So there was part of the cefotaxime drop was a switch of antibiotics. So if you combine all 3rd generation cephalosporin, there will be a great decline in their use. And these effects of antimicrobial stewardship in this pediatric intensive care unit wouldn't happen without the collaboration of a big teamwork. And the treating team here really wanted to improve the antibiotic prescription practices in their ICU. And that's what led, as I believe, to the great impact, as where most of stewardship rounds recommendation were followed. I don't have the rate exactly, but it's more than 80% of all recommendations were followed. And that's what led to the decline in antibiotic use. And this decline, everything was measured during that period. There was no change in disease-related complication. There was no change in ICU-related mortality. And there was no detrimental effect on patients. At the end, there are 3 references that I encourage people to look at if they want to establish a stewardship program. The first one is the IDSA guideline on implementing a stewardship program. The second is a CMR, the clinical microbiology review on antimicrobial stewardship initiatives in the microbiology lab. And finally, there's an excellent course done by Stanford University. It's free of charge. It's online. You can do it on your own base on how to implement antimicrobial stewardship and what are the targets and the outcomes that and how to optimize antimicrobial therapy. So thank you for listening, and I'm sorry for going over time.
Thank you so much, Dr. Mohammed. It was very nice summarization of antimicrobial stewardship. I really enjoyed it, and I really can listen to you for hours on this interesting topic. Actually, this topic has many challenges, as you already know, and we face lots of problems when dealing with clinicians and convincing them to follow recommendations as per guidelines. But I think we need more of communication, more of teamwork, as you have mentioned, and more collaboration between medical microbiology laboratories and the physicians as well. We have several comments and questions from the audience. And let me say, we have a few comments regarding that. As you mentioned, we have lots of abuse of antibiotics, and the person thinks that we need those kind of lectures to be shared more in our hospitals. The second comment is also from the same person, is that he thinks that we don't have knowledge about which practitioner is good and which one to trust, and who is an expert in antimicrobial stewardship and who is not. And I don't know what is your input about this part, because I think this is related to lack of communication and education.
Yes, I agree with the fact that there is wide use of inappropriate antibiotic prescription and indication. That culture needs to change, and it will not change within a day. It requires let's say it in like a healthcare worker community push, where every physician, every nurse, every pharmacist plays an important role in a stewardship initiative. It could be on an individual level, and in my experience, it's many physicians are willing to change the antibiotic. They just don't know why and how. If someone just give them 5 minutes of education on why this choice is better than that choice, and why we're going with that antibiotic and not this, most of them will agree and will change, as long as someone explains to them. And also, in many instances, you don't need to be an expert to create a change. If someone just identify, like if I'm a consultant in a medical ward, or I'm a consultant in an ICU, and I'm doing my rounds, if I identify one expert or one person that I trust, this could be a microbiologist, it could be an infectious disease specialist, it could be even a pharmacist. If someone who understands what are different classes of antibiotics and indication, quick 10 minutes chat over one or more patients could solve many problems. Not every antibiotic requires a consultation or a specialist to see a patient. Sometimes it's simple as, yes, this patient has methicillin susceptible Staph aureus, MSSA, in the blood. What should I do? Or he's on Peptazo, is it appropriate? It will be a simple answer. No, please stop Peptazo, start cefazolin or start cloxacillin. So these kind of answers doesn't require a consultant seeing the patient and could be done over the phone in a very quick manner.
We have one question also. From your experience, Dr. Mohammed, what are the challenges that you faced during implementing antimicrobial stewardship in Kuwait?
Well, there are many challenges, but they're all could be easily overcome. I think the main important aspect that you need to have in every stewardship program in Kuwait to have it going is to have a person in the treating team who's willing to change and he's pushing for a change in practices. Without that, you will be difficult even to move from step one. What I've seen and dealt with, if you're having, if the treating team is not interested in improving antimicrobial stewardship, whatever you do, you will not be able to change that. So having a champion is very important. Once you have that and secure a champion within a team, then establishing the stewardship team is just a matter of time and matter of effort, and not and it will not fail as long as there's someone pushing it forward.
Yes. One last question is from one of our colleagues. He's asking about the role of clinical pharmacist or the role of pharmacy in implementing stewardship programs, and if you can a little bit elaborate on this topic.
Well, pharmacists are a very important, have an extremely important role in the stewardship program. For example, let's say I'm doing the rounds in ICU as an infectious disease specialist. There's no way I could know every patient on antibiotics or who has appropriate use of antibiotic and who's not. A pharmacist knows all this information because all the prescription funnels through pharmacy, and they will know which patient on which antibiotics. And in centers where they have electronic medical record, the pharmacist will have an access to cultures, clinical data that could easily can look into whether the indication is appropriate or not, at least as in a rudimentary level. And if there is an appropriate use, for example, if a patient on aminoglycosides for 5 days, this requires a stop and think. Why a patient on aminoglycosides for 5 days? There are only extremely few indications that allows a patient to be on aminoglycosides beyond the 48 hours, 72 hours period. So the pharmacists have this information and can trigger a relook into the antibiotic. Of all specialties, pharmacists have an easy access and have a very important role in improving antimicrobial prescription without even having a stewardship program established.
Yes, there is one last question. Let me see, what is it? If you may allow me, Dr. Mohammed.
Yes, of course.
Yes. Yes, the question is, does Kuwait have a research project going on regarding microbiology aspect of antimicrobial drug resistant or appropriate use of antibiotics and implementation of microbiological intervention in facilities? It means that, do we have any national-wide project regarding antimicrobial stewardship, and antimicrobial resistance like antibiotics at the national level?
I'm not aware of any, but I might be wrong. But yes, I think at one point there was an initiative by the Department of Infection Control to establish teaching sessions on antimicrobial stewardship. But I'm not aware, and I couldn't when I was preparing for this lecture, I was trying to find like a good review of all organisms and the rate of antimicrobial resistance. I couldn't find one from Kuwait that compromises the actual epidemiology of AMRs. There are papers from Kuwait that look into a specific antimicrobial resistance in specific organisms. Like there are a few on Streptococcus pneumoniae, there are a few on Staph aureus, there are a few on gram-negative organisms, but there isn't one that looks on a comprehensive level. Also, unfortunately, Kuwait is none of the microbiology labs in Kuwait, at least on the previous reports, are participating in the GLASS registry, part of the WHO, where it compares antimicrobial resistance across different countries, at least to know where we at compared to other nations around the world. But I might be wrong. But this is what I'm aware of at the current time.
Yes. So we don't have any more questions. And at the end, I would like to thank all our speakers for their really nice presentations. I really enjoyed them all. And I would like to thank also our audience for their kind attendance and participation and their interaction, and our sponsors for their kind contribution, the GISS and Pfizer. And also to thank our moderators from Military Hospital, Dr. Mohammed Abul and Dr. Saud Sherida. And this webinar has been recorded in case if you want, anyone wants to see it again. It is recorded and you can see it on the website with the link that that has been sent to you. And this is it. And inshallah, I wish we can meet again next time, inshallah. Thank you, everyone.